Morning. Ladies and gentlemen, I can see that the crowd has decreased by half, or is it, or more than that. And I attribute that to the pleasant sights that you can see in Malacca. Am I right? Okay. So today I have a very challenging topic, which is death on the table and how one deals with the family. Now I say challenging because this is something that nobody wants to face, you know, and the repercussions of having a death on the table is very, very great. Now let me just start off the topic by talking a little bit about anesthesia. As we all know, now anesthesia is something that needs to be provided from easy to very complex operations, and it is one procedure that cannot afford to be botched up. Okay, botched up means that cannot afford to go wrong. And it is the understanding of the complexity of this procedure, and then you have to administer the correct amount of anesthesia, especially in operations which carry high risk. And even a small error during anesthesia can prove to be very, very fatal. You know, the misconception people have is that, oh GA doctors duduk sana put patient to sleep and then go for coffee. Tiba-tiba coffee again and coffee again. But you all are very, very wrong. Because unless you come and do anesthesia, then only you will realize that even though we may look as if we are sitting quietly, our eyes and our ears and all the other senses are always sharpened. And we are always looking out for small errors that can prove to be fatal. And it is also challenging to be an anesthetist because we have surgeons who come and make guruhara. Some surgeons are very nice. And you can see that the anesthetist is like a mediator, trying to get the operation done, trying to keep the environment as smooth and calm as possible. Okay? So that is how important we are, and I'm very glad that you are here with us to support. And that is why I want to make my presence felt at this meeting, because I feel you all are so important to the anesthetic department. Very common scene, isn't it? Operating theatres, surgeons concentrating on what they are operating, quite unaware of what is going on at the head end. And I wanted to take you through this topic by discussing about the common types of surgery. Now, very simple, elective surgery. What's elective surgery? Planned surgery, isn't it? And the other one is emergency surgery. So only two, elective and emergency. Now let's look at the scope of the elective surgery. Now, for an anesthetist, be it elective or emergency, we start with pre-op preparation. And our pre-op preparation is extremely thorough. Oh well, I hope so anyway. But look at this slide, where the surgeon comes in, looks at the patient and says, oh, don't worry, I've done this operation so many times. I'm sure I'll eventually get the hang of it. You know, so surgeons may or may not be good, but we try to be consistently good. Sorry, I hope there are no surgeons around. Now, pre-operative preparation, I hope that the font is clear. If not, I'll read it out to you. Prior to surgery, the patient is given a very thorough medical examination, and this is usually conducted by the medical officers in the anesthetic clinic or on in the wards during the pre-medication rounds. And we tend to review the pre-operative tests and the results and their physical status, i.e., you know, are they healthy, not healthy, sick, complicated, is rated according to the ASA physical status classification, where we divide them into ASA 1 to 4, 1 being healthy, 4 being very, very sick. And then if all these results are satisfactory, the patient will sign a consent form. You know, now you all know, isn't it? We have a separate anesthetic consent form. Very important document that has to be signed by patients before going for surgery. And if you all haven't been practicing it in your hospitals, high time you started so. Okay? Now, Once they have signed the consent form, after being explained in detail by the anesthetist on all the anesthetic disclosure on the risks that are going to be faced, we have actually created a rapport with the patient. Now, this pre-op preparation is common for elective and emergency, except that in elective, you have more time. Patient is healthy, you can ask all the questions, you have time to meet all the relatives, but in the emergency surgery or the emergency situation, there are some different issues. What can the issues be? Anybody? What's the difference between doing elective surgery, emergency surgery? Any issues that you can think of? One hand up please, so that I know you're listening to me. Alah, tak ada orang pula. Anyone? Makota? No? Okay, never mind. First, usually when a patient is coming for emergency surgery, is the patient healthy or not? Some are healthy, but some must be very ill patients. That's why we are putting them up for emergency surgery. So their hemodynamic status can be unstable. And because it's an urgent surgery, the surgeon says, I cannot wait very long, I need to go in. And therefore you don't have time to optimize. Time to optimize means to make the blood pressure come up, to make the patient as healthy as possible before he goes for the surgery. So we already have two issues when you are doing emergency surgery. And then there's this urgent indication to operate. And you can have surgeons breathing down the back. Maybe not for you all, but certainly for the anesthetist. What time can we call? Isn't it? You all are the counter nurses. What time can my patient go in? What time? Why you haven't called? Very common scenario, very irritating. Okay? And then, for the intensive care, we will be calling them and we say, we have this patient, ruptured aortic aneurysm, I want to do now. Oh, sorry, no ICU beds available. Maybe I will have one bed at 11 a.m. Once the patient discharged, then I set out, then I have to clean. Isn't it? Common scenario. Because the ward don't want to come and fetch the patient from ICU. We know all this. So there are no ICU beds available. And then the anesthetizing doctor will say, Ayah, how to go and do this if after that no ICU backup? So there will be delays. And worse still, sometimes there are no relatives available. And what do we do? Who are you? We'll ask if there's somebody there. You say, I'm the cousin. Okay, you sign the consent. Ini kena buat sekarang juga tau. And then you don't have time to explain all the risk disclosure, unlike in elective surgery, where you have ample time to say this thing can happen, B can happen, C can happen. So, totally different scenario for emergency surgery. Whatever it is, patient goes to the operation theatre, I showed you a picture, and suddenly something happens. And that is sudden death. And to the doctor, this is the worst thing that can happen. Okay? Once you have sudden death, not only to the doctor, to the GA girl who is there, you all, to the scrub side, to the surgeons, it's going to be an unhappy next few hours, I can tell you. So let's look at some of the issues one is faced with when you have a death on the table. What is the first thing? Say Anwar calls me, boss, I was doing this case, sudden death. Inside my mind, was it expected or not? Anwar, did you think that the patient was going to die? Does it make a difference? Yeah? Does it make a difference if it was an expected death? Yes. Why? Because you would have at least told the relatives lah, this patient really teruk sangat, mungkin nak selamat pun susah sikit, tetapi we want to give a chance, we will go in. So that is the reason why I'm thinking, is this expected or not? Was it elective or emergency? Were the relatives forewarned? Anwar, did you take anesthetic disclosure consent? I will ask him. If he said, yes, I told that there will be aspiration, I told there will be cardiorespiratory arrest on the table, lega sikit. But if not, I can just imagine the tension and the drama that is going to be there when we break the news to the family. Then I will say, who was the surgeon? He said, junior doctor. So what did he do? Oh, I think he cut the IVC. Alamak. So we know it's double dose trouble, isn't it? Because no doubt it's not my headache. But when we give gas to a patient, it already becomes a combined team effort. And you cannot say it's a surgeon, yes, salah. No, when we give gas, we also party to it. So it becomes both our headaches. And then this MO has gone and cut the IVC. Okay? So I want to know whether any mistakes are made. Because if there are mistakes, then we have to plan what we are going to tell and how we are going to break the truth to the relatives. How junior are the doctors who handled it? Okay, if he says 2 years, okay lah, 2 years better. So when we explain to the relatives, we will say this is not so junior, he was 2 years senior, he has done many operations, dia bukanlah baru, orang baru. But if this let's say, oh baru 2 bulan dalam surgery, the patients are not going to be very happy. Then you go and let a 2 bulan uncredentialed, unprivileged person to do the surgery. Then I'll be saying, now what to do? What to do? So you must remember that there is a logical sequence to everything. Don't panic. Important. The doctors mustn't panic, and they mustn't make the nurses also panic. You know, when the doctors panic, they will shout, shout, shout. Nurses also will become panic-stricken. So don't. All must remain calm. There's a logical sequence. Remember, you have time not to be completed in one breakneck speed. You take your time and decide what you want to do. So what is the preparation? First, if the doctor was not there and the patient died or whatever, call your consultant, brief your consultant. Very important to engage the highest authority. That is the first message. Even if you forget all that I tell you, remember that. Tell your boss what has happened. You must know all the facts. You go and ring your boss up, but you only know the cerita setengah-setengah tu, jangan. Get all your facts straight and explain to the doctor what has happened. And it is very important, because we are anesthetists, that we must also get input from the primary unit consultant. Example, if it's a ruptured aortic aneurysm, from the vascular surgeon. And then we discuss, this is what happened, this is the problem that went wrong, and what are we going to disclose to the relatives. So remember, it's logical. Don't hurry through your explanation. Plan what you're going to say. Discuss with the surgeon. Otherwise, the surgeon got one more cerita, you all got one more cerita. Okay? So plan what you're going to say. And always let the senior person handle the situation after you rehearse what you want to say. Now, a common scenario when we used to be in Malacca, in ICU is, we always call Dr. Zainal to break bad news. You know why? Zainal's command of the Bahasa is very good. And he will always bring God into the picture. And all the Malays are able to accept it better. He's really good at breaking bad news, if you ask me. But before he breaks the bad news, we will call all the senior person in the department. And we plan what we want to say. We rehearse the perkataan so that we don't get caught. Okay? And this is the most important part. You will let the senior person handle. So because my Bahasa is not so good, I will let Dr. Zainal speak, but I will be there so that any questions can be directed. It's not that I can't understand Bahasa. So I can also chip in and tell them the right thing. Okay, so preparation, extremely important. So you prepare yourself. On your marks, get set, go. How do you get started? You will have to find out who is going to be present to terima the news. Which relative is it? Now, often we just break it to whoever is there. But it is important that you must break it to the closest relative possible. You must ensure privacy. The one thing you mustn't do is to go out to the airlock. Adik, minta maaf ayah tu dah meninggal. Cannot. You mustn't do like that. You must bring them to a room or at least find a corner somewhere, make them sit down, ensure that there is privacy before you break the bad news. Always confirm the medical facts. I already mentioned that to you. And you ensure that all information is available, so that you must already think, what question the relatives will ask me. So I will ask, I'll say, Dr. Lim, TC, tell me what you think the relatives can ask. Or then I'll ask the nurse. Example, say Zaida was the ICU nurse. What do you think they will ask? Then say, maybe they will tanya macam ni. So already we prepared the answer, macam ni to jawab balik. So you must ensure all information is available. And you must anticipate questions that are likely to be asked. And you must anticipate the responses that are likely to be shown. Now, if it's an elective case, you probably already know some of the relatives. But if it is an emergency case, you don't know how the relatives are going to react when you break the news. Okay? So you must anticipate that it can be a calm situation, or it can be a very, very explosive situation when you break the news. And rehearse what you have to say, and you must introduce yourself. Okay? And when I say introduce yourself, you must say your name and what is your designation. Example, I'm Dr. Sakthi, I'm the head of the Department of Anesthesia. Okay, you must tell your post. Sometimes I find our Asian culture, kita malu, to introduce ourselves. We say, so, saya Dr. Bius, something like that. Cannot. You must tell your name so that the patient has confidence in you and patient doesn't think that you have something to hide. Okay? Now, you must create an environment conducive for communication. Like I told you, not on a corridor, busy corridor with patients being wheeled in and out. You probably, if you don't have a room, maybe take to the sister's office or go to the Jabatan NS office when you break all this news. And sometimes, because it's an urgent operation, they would have been called in a hurry to come. They got nobody to jaga, the anak-anak, all the children also come along. And you don't want the children to be distracting when you're breaking the news. So you may want to have some staff to attend to these children when you're talking to the relatives. And you must give yourself enough time. You cannot say, okay, I have to break the news, but in 2 minutes I have to get up and go, cepat-cepat, ada apa-apa soalan. That cannot. You're going to break a bad news, so you need to give them time to ask you questions. There's no cepat-cepat, can I do anything? You have to allot specific time, adequate time for them. And you must ensure that there are no interruptions. The last thing you want when you're breaking the news, the boss's phone rings, and then you say, yeah, and then you chit-chat for half an hour. Cannot. You will put down the phone and say you'll call back later. I'm in the middle of something that is very urgent. You must ensure privacy and you must ensure adequate seating. There must be enough chairs all around. And very important, the box of tissues. Okay? Because if they're going to cry, at least you must be able to anticipate and cope by having a box of facial tissues. Now, remember I told you there's two scenarios, elective and emergency. And if it's an elective scenario, you may want to know what the relatives know already. In elective surgery, it's a bit different scenario. These patients are seen in the NS clinic. The doctor who sees in the clinic is a different doctor. The specialist who sees in the NS clinic is a different doctor. But in the operation theatre, it's a different specialist who is anesthetizing. Often we communicate with one another and we look through the GA form and we see what all has been explained, especially if it's a difficult case. But if you haven't had that opportunity to find out what was explained to the patient's relatives, you may want to start the discussion gently to find out what has been told to you so far. Now, Did the doctor in the clinic tell you about this patient's surgery? You know, gentle. And you must exercise the younger generation. Soft skills very kurang. Very kurang. Okay? And it's not easy. None of us are born that we are able to exhibit soft skills all our life. Soft skills you must cultivate, you must practice, and you must develop your soft skills. You cannot just say, oh, saya ni memang orang kasar, saya tak boleh lah buat macam tu. You know, cannot. You must learn how to do it. And the bosses must make sure you learn your soft skills. So ask, what do the relatives know about the surgery? What were their beliefs? Did they believe that this patient is going to be 100% alright? He's going to get up, he's going to walk away? Or did the doctor actually say that something might go wrong? And will his family be able to understand that bad news? This you have to figure out. And that will help us how to introduce the news. So if it's an elective surgery and then he tells you, yeah, doctor, memang Dr. Buse ada cakap that he will have a cardiorespiratory arrest sebab dia obese sangat, mungkin dia boleh aspirate atau mungkin tak boleh intubate. So thank God lah, he already knows about it. But if he says, no, tak ada apa, nothing was told, then you cannot quickly drop the bombshell. You must go slowly, drop fact after fact so that they don't get terkejut. So this is what I say, your soft skills must be maximum. Now, let's look at how much the relatives want to know. You find that because we all are different cultures, different backgrounds, I find that sometimes breaking news to the Malays a bit easier because they tend to take it as, well, it's God's will that he dies, you know, sometimes. But some other races, I mean, certainly Indians, you know, they'll scream and shout and yell and like gangsters, you know, 0408 type of people in that kind of scenario. And so different people will react differently. The educated ones may be angry, but they may not shout. But the lower category, sometimes, if really bodoh, they don't know, they'll just terima. But it is the teachers category, teachers being teachers, they have this questioning mind, and the way they correct out of you, you already know which direction is this discussion going, whether they're going to sue you or not. So remember, when you're breaking the bad news at the back of your mind, we are going to get sued, we are going to get sued. So what we tell. And sometimes some relatives, they just say, oh look, I don't want to know, he's gone, he's gone. Please don't tell me anything anymore. Okay? You must respect his decision. You cannot say, no, I want you to hear what happened, because later you might sue me. No need. You write in the ticket, we attempted to explain. But this relative did not want to listen to the details of the case. Always remember, have a witness next to you. And some relatives, because they are so upset, my anak just died, they don't want to be the one who is listening. They may say, okay, this is my younger sister, I want her to be the one to communicate on my behalf. You must respect that also. You cannot say, no, I only want the parent. You must have the parent there, but you may explain maybe to the auntie. Okay? Now, deliver the information in a very sensitive but straightforward manner. Now that is what I say soft skills is all about. Very susah. Sensitive but straightforward. You want to break the news, but you must choose the right words. Okay? And then, avoid delivering all the information at one go. Okay? Don't say A to Z without pause. All this happened. The fellow also confused. You must pause, stop, and then you look at them. Say, do you understand? Do you need some time before I go on with my explanation? Do you want to ask any questions now? So your voice also must be tenang and calm, and don't agitate the family. If your voice is defensive, they will get angry. I just give you one scenario. I mean, nothing to do with bad news, but I'm talking about soft skills. I had one specialist who, when she was attempting to intubate, of course that patient has to be a nursing tutor somehow. Attempting to intubate, she had a difficult intubation, and the nursing tutor's tooth fractured. And the nursing tutor says later when we asked her that during the clinic visit, she had mentioned, no, I have got a bridge here, so please look after my bridge, etc., etc. But again, not documented because the MO, whoever took the history, didn't document. So after that, the son was a bit upset, and we knew, so this anesthetizing specialist went to explain. And the way she explained, he got more angry. It's like, she's trying to be defensive to say that it wasn't their fault. These things always happen when you sign the consent. It's in the consent form. It's already written there that you may have sustained injuries to your mouth and oral cavity. But the guy got irritated. The way she explained, tiba-tiba he went to the hospital and lodged one long written complaint, and then we have to have inquiry. All this over a fractured tooth because the doctor doesn't know how to explain gently and professionally. So that's what I keep saying, your soft skills are very important. You must be silent sometimes. Use your body language to facilitate the discussion. If your body language is like mara-mara and defensive, they get irritated. Okay? And don't try to minimize the severity of the situation when trying to console the relatives. Don't tell them, tak apalah, ini sikit je. I mean, somebody has died, you can't say ini sikit je. Janganlah nangis, they're already crying, you must let them cry, let them voice it out. Don't try to make it like it's a small thing, event that happened. What are you making that kind of noise about? Don't do that. And use simple language and avoid medical jargon. That means basically use simple language. How to break the news? First, use words such as, well, I'm afraid, or I feel bad to tell you, or I was hoping to give you good news, but unfortunately, I am the bearer of bad news. Something like that. Start slow, okay? And don't use the word, I am sorry. Why? Because when you say, I'm sorry, they might think that you are guilty. Understand? So don't use the word, I am sorry. You just say, well, I feel very sad to tell you, we looked after the patient to the best of our efforts, but we were unable to keep him alive. We did everything that we can, etc., etc. But don't go and say, try to avoid using the words, I am sorry, simply because they may think that you are the person responsible for the death. But if you want to say, I'm sorry, to show empathy, like, I'm sorry to have to tell you this, that's okay. But don't say, I'm sorry that this happened. And then, how one responds to their feelings. You're telling the news, they obviously are unhappy. There will be different types of reaction. You must give the family time to react and express all of their immediate feelings. Don't try to shut them out. Don't try to say, look, I gotta go. I cannot be here with you. No, you must give them time to express all their feelings they want. You must be prepared to support them through a broad range of reaction, from being quiet to being violent and wanting to come and hit you. You must listen quietly and attentively. The problem doctors have is sometimes they think they know a lot. They want to get the last word in. But we are very poor listeners sometimes, Sometimes it's just good to keep quiet and listen to what the fellow has to say. He already feels better because he has ventilated whatever he has to say. You must acknowledge their emotions. You must empathize with them. And this is something very difficult, isn't it? What if they cry? First, like I told you earlier, have a box of tissue paper ready. And this is something I learned, you know, this is aside from bad communication. Every 6 months, I do postings for the doctors who have passed, you know, the specialists who have passed. And unfortunately, some specialists will be posted in West, majority have to go to East Malaysia. And you say this one Bintulu, this one Sarike, this one Tawau. At the end of 1 hour, they'll be weeping and weeping and weeping. After that, I learned. First, before we start the posting meeting, we have the tissue box down there. Because they got no tissue also to, you know, when they are around. So very important. This is something I really learned. Practical point. Have the tissue box there. Allow them to cry. Now, after some time, they are crying. You have to continue talking. You express your empathy. And then you say, I'm sorry to have to give you this type of news. Please realize it's also not easy for me. And I know that you were not expecting to hear this. So your voice must be lembut. You must sound as if you are also suffering like them, so that they don't get agitated. Understand, the point I'm trying to say is your voice mustn't make them irritated. Okay? And do not cheer the relatives by false hopes, or even talking philosophically, you know, say, oh well, I'm sure you all realize when somebody is born, everybody knows that whoever is born has to die one day. So well, what to do? You know, don't talk like that. They already upset that their 17-year-old son has died, and then you go and say, yeah, when you are born, you know you're going to die. So what? You know, cannot talk like that. Huh? But something for the doctors also to take note, or even for the nurses to take note. What if the relative is angry? It's a very common scenario, isn't it? They can get angry. First, you stand up. Once you stand up, it shows that you are prepared to handle this situation. So you stand up. You continue to be polite. You also cannot shout back. No, obviously then that's not professional, isn't it? Then they can sue you for something else. You continue to be polite and firm. And then you must say, you know, I'm sorry to have you to give, you know, to have to give this type of news to you. You are upset. You are annoyed. I am happy to answer any of your questions, but be polite, firm, stand up, be in control. And if you fear your safety, leave the door open, or you leave the room. This font is not very clear, I'm so sorry. If you have a colleague nearby, then that will diffuse the situation, or call for help if required, but maintain control. Now, the one thing that I have learned is never go in alone to break the news. You must take your senior colleagues with you. So if there is somebody next to you, they serve many purposes. One, as a witness, they have seen what you are explaining. They have seen what is the relative's reaction. They can confirm what you told, even though the relatives turn around and say that you didn't tell. And they can be there if the fella is violent. Somebody to support you. So whether you talk with difficult doctors, or whether you talk with difficult patients or difficult relatives, never do it alone. That's also something that I've learned over the years. Okay? Now some practical points. Okay? Try to be kind. They may have stayed the whole night waiting for the patient to come out from the surgery. You may want to offer them some drinks, some food. Allow frequent comfort breaks for the family and for yourself. Then you must ask them, do you want me to contact anyone else to be with you or to help you facilitate arrangements? How do we contact you if we need you? How do you contact them if they need them? Sometimes you may just want to leave the family alone, you know, amongst their kampong people, etc., to grieve and support themselves, instead of being like a foreign body in that group. You have to learn this from the environment you see when you're breaking the news. And be aware of the cultural differences. ask what is the practice in their religion and culture. Do not, at that point when they are already upset, go against their religious beliefs or practices. The common thing, isn't it, when someone is dying, they want to be around, they want to say a few verses. Now for Indians, we say we want to put some milk into their mouth, allow it, the patient's going to die. At least these kind of things will make them happy, and they won't then feel like making a complaint against us. Never let the bereaved people drive themselves. And sometimes you may think whether a future meeting is necessary, if there are any unsettled issues, certificates, medical reports for insurance or police. You may think about how is the family coping with the loss, especially in the early weeks and months, and remember that birthdays and anniversaries can be painful. But a practical point about this, if you were the anesthetizing doctor and the nurse, and it was because of the nurse's mistake that something went wrong, please don't be the one to call and say, how is, are you coping with so-and-so's death, because then that will reflect that you're guilty. You may get a support team in the hospital to call them and ask them how they are coping. But you please don't go and give your telephone number or liaise directly with them unless you're friends. And then sometimes they may even need psychiatric referral if their grief reactions are prolonged, severe, and causing functional impairment with or without suicidal intention. So it's good for the hospital to have a small team that will follow up on these patients, and without getting the people who are concerned in the case to follow up these patients, so that the patients don't feel that they have been left in the lurch, that nobody cares for them, mistake has been done, hospital not bothered. No, we had one incident where some injury to the young lady, and she couldn't walk, and the hospital went as far as trying to modify a bathroom and making it wheelchair friendly, etc. So I think those kind of things will make the patient's relatives at least feel happier. And this will be my last slide, ladies and gentlemen. Thanks for your attention. Do we have any questions?